on the screen and in your speaker packet that he's extremely accomplished, both as a TCM practitioner, but specifically with neuroacupuncture. He has many degrees, all in the right things, and he has really made it his passion in life, not just to practice this and to move the practice of TCM in neuroacupuncture, but also to prepare a certification and then a doctoral program to promote the profession. So you're a star, Dr. Corradino, and we're down to one bar on this mic, so you get a walk-around Vanna White mic.
All right. That's what I needed. Thank you so much. You're the best. Okay, let me put my water down over here. And I'll take this. Okay. So first, thank you very much for inviting me, Dr. Matecki. I really can show my gratitude and my humility to be here. I feel very honored to be here. I'm going to walk around and talk, by the way. I like to have my laser. And after what everyone just presented, this could not be a better presentation. I'm serious. When we just went over everything, what we're going to go into today is exactly what we should be integrating with 100% what we're going to talk about, okay? So let me see if I can get these tools together. So neuropuncture is the topic. So neuroacupuncture, I hear everyone say that, right? Neuropuncture is a system that I personally created, we'll talk about. Neuroacupuncture, unfortunately, is an area of acupuncture, but it's also another system. And since I trademarked this, because I'm happy I did, there's like about 5, 6 different now: neuroacupuncture, neurology acupuncture, nanopuncture, neuroexpuncture, which was actually a student of mine that now competes. I mean, it just gets crazy. So neuropuncture is what the topic of today is, and that's the system we're going to be talking about, specifically in neurodegenerative diseases. And I've been doing this for some time now. No financials. You got your learning objectives. All this work has been copyrighted. I've been in the field for 30 years. Since 2008, I first started teaching this and combining all this. We're internationally trademarked, and it is a patent pending system to protect you guys. So what's neuropuncture? I've been teaching this for 20 years now, and every time I go around the world to teach this, what do I always ask my students, my practitioners? How do you explain neuropuncture? You've been doing it for like 5 years now. Well, it's neuroscience, acupuncture, you target receptors, we look at nerves, and no one explains it right? And not that they don't explain it right, but it's just difficult to try to really grasp that. So I put this first sentence together very specifically using neuro-linguistic programming. And what this is this. It makes it very clean and tells us exactly how to communicate with our patients and our healthcare practitioners. So neuropuncture is what? It's the only complete neuroscience acupuncture system that specifically teaches the practitioners how to neuromodulate your patient's nervous system back into health using electrical acupuncture. That says everything right there. Complete neuroscience acupuncture, we have a full body system, incomplete or a complete and separate auricular neuroanatomy system, as well as scalp system to target cortical structures, subcortical structures, and circuits and signatures in the brain. So it's a complete neuroscience acupuncture system. We teach the practitioner how to neuromodulate. We don't do yin-yang, deficiencies, tonify. We're modulating the nervous system. So we have to understand how that works. And this actually comes from the Link Shoe. And how do we modulate our patient's nervous system back into health? We use electrical acupuncture, and that's our main tool for modality. Yes, we do use some maybe manual acupuncture in the ear, ASP needles to get a very strong response to communicate with the brain, or we might do some motor point needling around the body. But most of our stuff is all electrical acupuncture, and we'll find out why. What this is, everything has been all research supported. We integrate research of the physiological mechanisms and electrical acupuncture, and this is what builds a lot of credibility with our language. We use 21st century neuroscience language to discuss our patient's pathology and our patient's treatment to our patients and our healthcare providers that refer our patients to us. All of our prescriptions are patent pending, neuroscience, evidence-based, research supported, and we're gonna go over this today, you're gonna love it. If I say do this note at 4 hertz, it targets GABA, got that from research. And now I know if I do that on my patient, I'm releasing GABA in the brain. And what we're going to learn to do, neuromodulate is just a nice big word, meaning that we're going to communicate, we're going to be affecting and impacting the nervous system, but we use three nice words. We neuromodulate chemistry, we neuroregulate dysfunctional autonomic visceral spinal reflexes and signatures, and then we neurorehabilitate structures and tissues in the brain. Again, all research supported. Medical disclaimer. This is for medical information, not to treat yourself. If you have any conditions, seek out a neuropuncturist. And there is, oh, this is a nice one. So Chinese medicine and acupuncture have very old ancient roots, right? Some people don't even know how old acupuncture is. Some people think it's 5,000, 10,000. It's about 2,500, 2,200 years old. Oldest needle dates back to about 200 BC, the Han Dynasty. So it doesn't go back 5,000 BC. That's a very misunderstanding. About 2200 BC. But what we're finding is that these intuitive, ancient intuitions are now being confirmed with neuroscience. And we see something in Stanford last year with Huberman, that the willpower is what? The mid-anterior cingulate cortex of the brain. So we can develop willpower by actually stimulating, by doing things we don't want to do, to develop willpower in our brain. So patients that might lack the will, have them start training things to do things that make them uncomfortable, but do it, and actually develops the mid-anterior cingulate cortex. So what we're seeing is, I think there's a lot of that ancient intuitions that we're seeing now in neuroscience. Now, I believe not only does neuroscience explain all of acupuncture's powerful, widespread impact on various health conditions, but it benefits also that the investigation of the ancient classics can then illuminate areas of neuroscience that we have never looked at. This is 2,200-year-old medicine that they knew how to modulate the nervous system. Gallbladder 37, does anyone know that? Guangming, it's on the lateral side of the leg. What does that mean? Bright eye. So when they needled that, they noticed vision got better. Now we know with fMRIs, you needle it, E-stim at 2 hertz millicurrent, occipital lobe lights up, and the visual cortex increases metabolic function. So needling gallbladder 37 actually stimulates the visual cortex. So it is all neuroscience. And to me, I love Taoism. But to me, the 21st century Taoism is neuroscience, because neuroscience, I think, explains everything now. And the thing that we always say is, once you see that neuropuncture constellation and how acupuncture works, you never can unsee it again. So once you learn it, you'll be able to see in so many ways of what you're doing and how it's impacting our patient system. Okay, this is the neuropuncture trinity. This is something I started 20 years ago. We're always modulating it, modifying it, and evolving it based on neuroscience. We follow the sciences. The first section is the neuropuncture neurophysiological mechanisms. That gives us the ABCs of all acupuncture, the neuroanatomy, neurochemistry, neurophysiology of acupuncture. Once you understand that, you'll be able to observe other systems and look at your prescriptions and understand how those are actually impacting the nervous system. The neuropuncture treatment principles teach us two things. If there's any special needle technique that we need to maximize the neuromodulation, and how to create the neuropuncture or acunode selections or prescriptions. We don't like a lot of nodes. We like to keep them small so that the nervous system gets a clear signal message. And then the neuropuncture electrical techniques, since we're using electrical acupuncture, we're not tonifying, sedating, we're sending electrons into the body. We need to know about the electrical sciences. And that, what we say, teaches us our neuropuncture dosage, which is the electrical parameters. Okay, we have a neuropuncture clinical assessment. So for Parkinson's, what we're going to do is we're going to look at that underlying neural root pathophysiology. We don't do pattern differentiation. I'm not going to look at liver wind. I'm not going to look at kidney yin. I want to look at the underlying neural root pathophysiology. We're in the 21st century. Pattern differentiation was created 2,200 years ago for a reason. It got the physicians to look away from shamanism and look at the human body, the organ systems, and the environment they live in. Now we're in the 21st century. Now we could see inside the body, and we could find out exactly what's causing our patient's pathology. And then we target that and we treat it. So for Parkinson's, we do neurological exams. We have UPDRS scores, which we'll talk about. Functional neurology is a great way to assess patients. We may have MRIs or DAT scans we'll talk about. And then we could do some neurotransmitter tests as well to see really what's deficient in the patients. And then we have a clinical process. So once you find that underlying neuro root pathophysiology, we put that back in that chart I showed you. And once you understand that, if we do not have already a prescription and a dosage like I'm going to show you today, you can create your own. So we say in neuropuncture is we don't want to just give you the fish. We want to teach you how to create a fishing rod so that you can catch your own fish, okay? Okay, we do keep a holistic health approach as well. Again, we integrate auricular, the scalp, and the body systems together for full prescriptions. You'll see that today. We combine a lot of other modalities in medicine, whether it be mindfulness approaches, diet, functional medicine, herbal medicine, injections, whatever else we do. And what this gives us is provides us nice fundamental neuroscience-based body, auricular, and scalp acupuncture prescriptions for maximizing neuromodulation. We have 3 fundamental truths in neuropuncture I always like to talk about, because this is important. First thing is that acupuncture is neuroscience. It always has been. If you look at the Link Shoe, it says that in chapter 1, that the nodes, when I read the Link Shoe, I cross out meridians, and I put pathways and networks. When I see chi or energy, I cross it out and put vital breath. Those are translations that doctors used in the 1600s to translate the Link Shoe, because it's a medical text. And when you reread that, it'll say the acunodes and the jinglos and mais are not found. Muscle, skin, muscle, bone, tendon. Anyone that does any human dissections will know gross 2 structures they're not naming. Veins and arteries, right? So that's what they were talking about. And it always was neuroscience since the Link Shoe. The Da Chi sensation is obviously runs across the afferent system of the nerves. Research does show that EA is superior to manual acupuncture. Definitely for gene expression, target receptors, and for neuroplastic changes, absolutely. And then how does electroacupuncture work? By neuromodulating, neurorehabilitating, and neuroregulating the nervous system back into health. Okay, Parkinson's. I think we had some really great discussions already on Parkinson's. So I'm gonna go through some of this a little bit faster because we don't need to go through some of the things that we just went through. So a brief little history of Parkinson's. It's not a new disease. It dates all the way back to Ayurvedic medicine, which is about 1500 BC to 2000 BC. And they had it in the Sanskrit. And then does everyone know Galen? Who was Galen? Galen was Marcus Aurelius' imperial physician. He was amazing. He was also Commodus' imperial physician. It's about 180 AD. Why am I making a big stink about that? Who from Chinese medicine was 180 AD that we love? Joel. Huatou. Huatou. Who created what? The Huatou Jiaji points and the back shoe points. And if you do any human dissections, you're gonna know that that's the dorsal rami. And he absolutely saw that. Galen knew back in this time frame the difference between an afferent and efferent nerve, 7 of the cranial nerves, and named the diencephalon and named the pineal gland. So they were very aware of neuroscience and the nervous system in this time frame. But Galen did talk about shaken palsy. Chinese medicine talks about liver wind. Parkinson's was first really described in 1817 by James Parkinson, and then Jean-Martin Charcot really categorized it, found the basal ganglion, the dopamine deficiency aspect of it, and he really was actually awesome enough to name it after the guy that really started it, which is mad respect. After him, after James Parkinson's, then it was Parkinson's. Okay, so what is Parkinson's? So we talked about this today with Dr. Collins. And in short, it's a progressive neurodegenerative disease. So there is no cure for it right now. I'm not saying that we're gonna be doing any cures right here. I'm sure there's greater neuroscientists out there working on these types of problems. But I'm gonna show you some really cool work that we're doing. It is an impairment of the depletion of the dopamine generic system, so there's not just dopamine deficiency, it's the neurons themselves that atrophy. So it's kind of a 2-part thing. And like the good doc said, it is not just a movement disorder, you know? ALS, movement disorder. Dementia, cognitive disorder. Parkinson's, everything. There's neuropsychiatric conditions, there's motor conditions, as well as emotional conditions and autonomic failures. The 4 main cardinal symptoms we see is that resting tremor, right? Patients will say, you know, doc, I don't know what's going on. I'm watching TV and the remote just jumps out of my hand now, you know? And I'm just sitting there, my hand's shaking, I can't stop it. rigidity of the muscles, bradykinesia, postural instability. Is there anything interesting between those symptoms? So resting tremor is the inability to control. Bradykinesia is the inability to move. So you see actually polar opposite symptoms. We're going to look at why that happens. Other symptoms that very commonly come along with Parkinson's, sometimes before those four, is a lack of facial expression. Patient may come in and be like, yes, so I took my grandson to the zoo this weekend, and it was great. And then my wife and I, we had some drinks, and their face is just very mask-like. They could have difficulty speaking, blurred vision, gait shuffling, and loss of sense of smell. COVID crossed over a lot of that. We'll talk about that. And then we have a common picture that we see with Parkinson's. They tend to lean a little bit forward because the neurodegeneration is telling the brain that the body's in front. So they start to walk like this a little bit, and they shuffle. Sometimes they freeze, and then they have to start going again. And again, we have tremor and slow movement, opposite actual functions. So this is why. So what structures now are causing this condition that we have to focus on, that if we correct it, they won't have the condition anymore? Well, it's definitely the basal ganglia. Substantia nigra is actually what produces the dopamine, nigra meaning black. In the scans, it's actually dark when they do scans of it. The putamen is where the D1 and D2 receptors are, which we'll talk about. And then the VTA, the ventral tegmentum areas, are the other big dopamine-producing centers of the basal ganglia, and the only two centers of the brain that produce all the dopamine. That's cool. Right now, like the doc said before, there were no lab tests and images before. So patients like Michael J. Fox, he wound up having symptoms, and he didn't get diagnosed until he had the full-blown symptoms. And one of the things that's really fascinating, if you watch, I think it's part 2 or 3 of Back to the Future. So sad. He runs to his car, and his arm doesn't move. And that was before he got diagnosed. And so when you watch your patients come in, like the doc said, I always observe that. Are their arms swinging? Are their gait shuffles? Are they walking, heel to toe? Are they straight? Are they being able to turn properly? Are their arms swinging a little bit? If you see one arm not working, right side, check left brain, but there's other things you want to consider as well. Okay, so there we have the basal ganglia, right? We got the thalamus right underneath it, right? So we have the brain stem. All the information that's coming from the body has to get into 31 pairs of the exiting spinal nerves. Then that goes into the spine, shoots up to the brain, hits the thalamus. Thalamus is the relay station. It's gonna be like, okay, where do we go? Where do we go? Let's go there, let's go there, let's go there. The basal ganglia is right over it. And the basal ganglia is what refines and regulates the movement signature. But is that all it does? No, it refines and regulates movement, cognition, and emotion. That's why basal ganglia is also implicated in antipsychotic medications. That's why they have tardive dyskinesia afterwards, after those medications, because the D2 pathway is getting damaged. So it's a signature that runs through, originates in the basal ganglia. There are other movement disorders. Doc talked about that before. This is resting tremor. Someone that has reaching for something, that's more cerebellum, that's an intentional tremor. You could ask them to touch your nose, finger to nose. If they push their nose real hard, patient's probably just trying to cover up, they're embarrassed. So just tell them, why don't you stop maybe an inch off the nose? And they'll be like, okay, that's intentional, that's more cerebellum. We have resting tremors with Parkinson's. Other movement diseases, really bad, Huntington's, we don't have any treatments for that. That's a really difficult disease. There's other Parkinsonian presentations that are not degenerative, and then multi-system atrophy, which involves multiple systems and can present with Parkinsonian-like symptoms. Statistics, in short, they actually are definitely larger. It's growing pretty substantially, and there's definitely a large impact financially on the world. It is the second most common neurodegenerative disease next to Alzheimer's. And is there a COVID-19 connection? What do you guys think? So, what's interesting about COVID, and you guys, I'm sure everyone knows this here, it is not an isolated respiratory virus, right? It goes many other places, unfortunately, right? It travels to the heart, it can go to the liver, it can go to the spleen, it can go to the spine, and it can go to the brain. And what's really wild about the COVID virus, it has a very selective area that it attacks, the dopaminergic system of the brain. So they're seeing signs of that in that invasion because of COVID infections. So we're seeing that it has an actual selective susceptibility right to the dopaminergic system. So COVID does have an impact on potentially increasing some of those rates that we're seeing. How does it get to the brain? Well, there's a couple different ways, right? There's a gut-brain axis that gets connected through the vagus nerve, right? So when there's leaky gut syndrome, maybe the patient's sick and they're starting to get some abdominal or gastric issues, there could be some leaky gut syndrome, and that actually can take that virus and push it up into the brain and then cause a leaky brain syndrome, which actually that we think might also play a role with like long COVID. So we see this connection. Okay, so like we talked about, there's motor skills and non-motor skills, okay? Again, don't forget that sense of smell that sometimes is the first one, and why do you think that happens? I don't know if we're gonna go into etiologies too much because it's an unknown etiology diagnosis condition, but pesticides seems to be sometimes of a contributing factor. A lot of my patients seem to either own farms or grew up on farms, and the olfactory nerve being the first cranial nerve goes right to the brain. So sometimes people say that might be maybe one of the entrances. Okay, now let's go back to that neuropathophysiology. We talked about the basal ganglia, right? But what's really important is we gotta look at these two pathways, the D1 pathway and the D2 pathway. They're dopamine-dependent pathways. The D1 is the direct pathway. It's an excitatory pathway. Remember, it wraps around the basal ganglia. The basal ganglia gets a transmission and it says, I gotta go there. And then the thalamus says that. And then the basal ganglia will either excite that transmission to get it where it needs to go, and that's D1, or D2, it'll slow it down. You don't have to go there too fast. Let's take it easy. But when it's pathological, the D1 pathway that speeds things up, slows things down, and you got bradykinesia. When the D2 pathway is damaged, instead of slowing things down, it can't. So they're shaking, right? That resting tremor. So it's the D1 and D2 pathways that we really need to focus on to correct, to prevent, and kind of manage the condition. This is a basal ganglia again, sitting right on top of the thalamus, brainstem. There's a nice slice, and here we have the putamen, where the D1, D2 receptors are. We have the cortical nucleus here, the thalamus is right there, and then we have the substantia nigra right there. And I think the putamen is right here. So we have all these little nice structures. And this is what happens. So that signature to move initiates prefrontal cortex unconscious, goes down to thalamus, basal ganglia, boom, boom, jumps back up to the frontal lobe where the motor strip is, back down to stimulate the cortical spinal tract so we can move, right? But look at this, at the putamen, where those D1 and D2 receptors are, it's damaged. There's neurodegeneration, and what happens is that signature gets stuttered. It gets like a hiccup in there, and it starts to impact the patient's physiology. So this is the picture that I love. This is the picture that really, I think, puts it all together. So these are the D1 and D2 neural circuits. What do we see here? We see what? We see different structures, right? The blue, right, or purple, I'm colorblind, sorry. That's the thalamus, right? Here's the putamen. Here's the substantia nigra for dopamine. There's the corteus. What do we see though? D1 and D2, right? They go up to the cortical structures because that's where the frontal lobe is, that's where the motor cortex is. But what do we see? It's not what? It's not just dopamine dependent. Look it. It's not just dopamine. We need GABA. We need substance P. We need glutamate. We need enkephalin. So dopamine alone is not going to complete this signature. So this is why we put together the neuropuncture prescription based on this neurophysiology and neurochemistry. when we look at UPDRS scores, we're looking at motor, part 3 is the motor examination, and this is basically a score that's used definitely nationally. I was in Israel doing some work, and they'll show you some videos. I think they use this as well. So does UK. I think Australia as well. If anyone knows if it's worldly, you could let me know. Then there's also DAT scan imaging. And before DAT scan imaging, yes, patients didn't really go diagnosed until they saw an actual image of the dopamine generic system shrinking. Then they had a definitive diagnosis, and they can start treating them. My uncle actually specializes in this. There's an actual image. I think we just saw this one with Dr. Collins. And then we have basically those little quotation marks that should be like that, but they are a lot smaller. And that's the abnormal scan showing the reduction in the neurodegeneration of the dopamine generic neurons. We also use dry urine tests to check for the neurotransmitter of dopamine and tyrosine, amino acid tyrosine. And we use a ZRT laboratory. And right now, recent treatments for Parkinson's, there's medications, there's deep brain stimulations, and I think a doc did say this, and from my understanding, most of the time, the medication in 3 to 5 years starts to decline. Same thing with the deep brain stimulator. And like the good doctor said, what happens with, should those patients not be doing when they're taking that medication? They should not be sitting down watching TV, because the medication is gonna make them think that they're doing better. And now that time frame when they're thinking they're doing better, they should be working on their brain to make neuroplastic changes. And they don't do that because they're on medication, and now they don't have the ability to sometimes. So medications, and some neuroscientists I know really try to get patients to steer away from this. I don't mean to offend anyone, obviously, just because of that. If the patient isn't engaged in their treatment, that could really slow down their benefits. Deep brain stimulator is a non-invasive surgery. You know, comes with risks. There's a nice X-ray image of it into the brain. Cause of Parkinson's, like I said, it's an idiopathic, unknown etiology, so unknown of disease origins or causes, and then some exposure to toxins does always seem to linger a little bit. We see with recreational drug uses, well-being toxins like, and trauma, right? Obviously, Muhammad Ali had Parkinsonian-like symptoms. So we see that. Okay, now let's go into some research about acupuncture and how well this will work on Parkinson's. So this is a nice little research paper, and I'm starting to find this more and more now, which I think is very exciting for us. That this was just particular to very classical acupuncture nodes. They e-stemmed it. What they found was that there was a nice statistically decreased number for the UPDRS score. So it actually increased the patient's UPDRS scores. 8 weeks later remained. But what really is beautiful about this is that last sentence. There was a positive correlation between the UPDRS scores and fMRI signaling and images. So, is there maybe changes in the brain that we can make with Neuropuncture's prescriptions? We'd have to test that. But there's research that's definitely showing this. And I've seen this with carpal tunnel syndrome as well, where if the carpal tunnel syndrome is in the wrist, if that's the lesion, what happens? That signal of the pain goes right through the median nerve into the 3 fingers all at once and simultaneously. So because the brain registers that simultaneous stimulation, the homunculus morphs together as 1 finger. And in the trial, what they did was sham acupuncture, balance method, and then I would say something like neuropuncture. They needled the nerves and stimulated. Sham was the worst. The balance method had very good pain relieving effects. The EA on the nerves had the best pain relieving effect, and the only thing that opened the hand on the brain of the map. So we might be able to make these changes in the brain, we just need to study it more. Okay. Another awesome paper. Again, 2 classical points. What is this going to do? It's going to inhibit the decrease, so double negative. So basically it helps tyrosine hydroxidase, which is an enzyme that breaks down tyrosine that helps to create levodopa, which converts now into dopamine. So there's classical acupuncture nodes that actually does help promote dopamine in the basal ganglia. And look at those points for my acupuncturist. Liver 3 and gallbladder 34. Is that not for liver wind? Of course it is. So when they did that thousands of years ago, lifting and thrusting, they were stimulating tyrosine hydrogenase in the brain. Dopamine was being produced, and the shaking stopped, and the wind was quelled. But it wasn't wind. It was dopamine in the brain that they were actually able to target. This is another trial, and this is a beautiful thing I see very repeated as well, the production of BDNF and GDNF, brain-derivative neurotropic factors, glial cell line neurotropic factors. Awesome, we can release that onto the brain to help heal the brain. We do that with a lot of prescriptions in neuropuncture. Awesome, that alone can be used for TBIs, that could be used for a lot of brain conditions. That was a nice one. So BDNF and GDNF always being produced. And then there's this nice antioxidant effect that we see as well that prevents apoptosis, so cell death. And what we really see with this is the production of SOD, superoxide dismutase, which is beautiful. Another thing that gets released in the brain from electrical acupuncture. So we're going to look at the Trinity. Looking at the Trinity as it pertains to Parkinson's, this is what we're going to look at. Okay, where's Parkinson's located? Central nervous system. So I want to know everything I can about Parkinson's. We just did that. Basal ganglia, D1, D2 pathways, all those wonderful chemicals that we need to complete that signature. Do we have any prescriptions in neuropuncture from research that we know will do that on the brain? Then, do we have dosages that come from research that when we stimulate those nodes, that goes back to the brain and does that? That was a rhetorical question. And then the clinical assessment, again, would be do maybe a functional neurology exam, UPDRS, check out the DAT scan, look at neurotransmitters. We put that back into Trinity, create a prescription, and this is the prescription that I came up with. This is not the first one. This is my latest refined one, where I'll show you the research that we have. So what do we look at? DO20 to DO14, Amiens bilaterally. Yes, you cross the spine, it's fine. And then gallbladder 34 and Tai Chong, we call that the deep peroneal neuropuncture node. So in neuropuncture, all of our acupuncture nodes or neuropuncture nodes, we put the nerve in the name so that we know we're stimulating that nerve. It's not an invisible pathway. If I needle spleen 6, Sanya and Jiao, I'm stimulating the tibial nerve. And I should really know where that transmission goes. That's our Jing Lows and Mais, because the tibial nerve will innervate the sacral plexus. The peroneal nerve will go into the lumbar plexus, and that's all part of the sciatic nerve, and that's basically spleen and liver. So you need to know those nerves. So gallbladder 34, Tai Chong, we call that the deep peroneal neuropuncture node. We have the dosages there. So on DO14 to DO20, we do 100 hertz millicurrent. And then Amiens, bilateral, and gallbladder 34 and liver 3, we go 2 to 4 hertz mixed milli for 30 minutes. So 1, 2, 3, 4 leads. Nice Pantheon. We use Pantheon devices because they're FDA approved. Unfortunately, there's a lot of un-FDA approved devices being sold to acupuncturists, so be careful. All the Pantheons are, so we use Pantheons. And those are the dosages we're going to use. Now let's break this down a bit and see if this matches the pathophysiology I went over before. What does DO20 and DO14 do? At 100 hertz, this is so much research behind this. It's not, we don't do that either. Look at one paper and this is what we work on. We look for multiple publications. I do it, then I give it to my instructors. They do it, then I give it to my gold members, my certification practitioners, and I get feedback from everyone, okay? This prescription, without a doubt, has been shown to target and activate the basal ganglia, modulate and modify dopamine, increase dopamine, and produce BDNF and GDNF and SOD. Beautiful. We have that in the basal ganglia. Amiens, bilateral, at 4 hertz, targets the GABA receptors in the cortical nucleus tractus solitaris, which is in the brainstem. Amiens does what? Peaceful sleep. GABA does what? Calms us down. That's why Amiens puts us to sleep, because it targets the GABA receptors. That's why neuroscience is so important with acupuncture. So now we have GABA. We need a GABA. Gallbladder 34, deep peroneal at 4 hertz, Lifting and thrusting a little faster will release that tyrosine hydrogenase in the brain to produce more dopamine. So we have tyrosine hydrogenase producing more dopamine in the basal ganglia. We have the dopamine center being stimulated in the basal ganglia, dopamine produced, BDNF and GDNF. We're missing enkephalins, substance P, and glutamate. Okay. Well, through Ji-Xing Han's work from Beijing many years ago, we know that 2 to 4 hertz on any peripheral nodes in the body, at 2 to 4 hertz, guys, it's actually even just 2 hertz, so lifting and thrusting for thousands of years, our practitioners were doing that. That was activating the delta and move receptors in the body. No questions about it. Delta receptor releases enkephalin. Awesome. Now we have enkephalin getting released at that dosage, okay? What about substance P and glutamate? When you study neuropuncture, those 5 neurophysiological mechanisms, the first one is the local effect. And what we look at is the special design of the needle. It's sterile, disposable, microscopically round, very flexible and filiform. When you insert it into a functional acupuncture node, there's an axon reflex. CGRP releases and creates a soup. What's the chemical constituents of that soup? 2 of the main ones, glutamate and substance P. It's also nerve growth factor, prostaglandins, white blood cells, red blood cells, serotonin, a lot of great things. But glutamate and substance P, locally, when that transmission makes it to the brain, guess what gets released? Glutamate and substance P. So now we have, let me see if I have that picture again, that whole signature with all the neurochemistry being supported with Neuropuncture's prescription, which is a peripheral nerve stimulation. That's why Dr. Chien, we should have some talks about this later on. Because that's the thalamus, there's the substantia nigra, there's the putamen, there's the corteus, and we have all that chemistry, the D1 and D2 pathways. So with our prescription, we are supporting all that and literally modulating and targeting the basal ganglia. Now let's see if that's really legit. The theory sounds great, right? All the science completely supports it and the research supports it. This was one of our doctoral candidates in our DNA program, Dr. Brecke, and she did hers on Parkinson's with this prescription. And this is where she published it. And I'm just going to briefly go through this. This is the abstract, and the abstract basically went over that she used the UPDRS score and a neurotransmitter test for dopamine and tyrosine. The methods we use, that prescription I just went over with the dosage, we publish this so that practitioners around the world can copy this. There was a paper I wrote with John Hubacher and Richard Nimsau specifically on our profession needing to record our electrical parameters better in research. And we wrote that many years ago before Richard passed, and we do that. So people can use this. If you want to learn the system to create your own, you study with me or us. But this is the prescription right here that we used. We have the needle size, the machine, the treatment plan, and everything. It was 12 visits, twice a week for 6 weeks. Sometimes we'll do 3 times a week for 4 weeks. That actually is, again, also research supported with gene expression, okay? The closer the periods of the treatment, the gene produces more expression where it's gonna produce more neuropeptides and stores it at the vacuole, at the vesicle. So if you stimulate your patient within 3 to 5 days, that doubles the gene expression. So that's why in classical acupuncture, we see patients twice a day, twice a week, 3 times a week, sometimes once every day if it's a stroke patient. Maximize that gene expression. And this was really cool, docs. I'd love to hear your interpretation of this one. So all of them had really good results. This patient had a 50%, these were independent assessed, by the way, by a neurologist, not by the practitioner. 50% improvement in their section 3 of their motor exam, patient 1. All of them had improvements. Patient 2 had a 25% improvement. But let's just read that last sentence because I don't even know where to begin with this. The patient 2 had a 37 decrease in dopamine, but remained in high range. And he had a 4% increase in tyrosine. So let me explain that. Before the patients got treated, we did a dopamine test. All of them were high. At first I was like, why would their dopamine be high? Because they're on levodopa and carbidopa, medications, right? So they're on medication. Okay, all of them are high. All of them are out of range. But as we know, Parkinson's is not just a dopamine deficient condition, right? Otherwise, that would be the cure to it. So they were all high. At the end of this one, it actually reduced 37%, but it still remained high. And the tyrosine increased. When the doctor was doing her final conclusion and assessment, the patient told the doctor she stopped taking her medication second week into treatment. And anyone that knows when they take the medications, just like the doc said, if they stop taking their medication, usually, or not stop, if they usually take it 9 o'clock in the morning, if they don't take it by 9:30, their symptoms can start coming back. And she actually told he told her that he actually stopped taking his medications to second weekend. So here's some just postural things, which was really cool. Again, they all improved, but you could see her posture changed so much, which is really substantial for Parkinson's patients. You could see how much straighter she is. Same thing here, this gentleman as well. You can really see how much straighter he's standing. This just goes over the prescription again. This is another case, 60-year-old male. He was diagnosed with Parkinson's in 2016. He has Parkinson's, stooped walking, inability to turn on one foot, tremors, and speech impairment. We all know what Parkinson's is. This was his drawing before the treatment. This was after. This was what he wrote. This was the practitioner wrote. This was after one treatment. It was amazing. He pushed himself off the table without shaking. He got off the table, and without thinking, he started walking. I asked him to speak, and he started speaking, and his wife had tears in her eyes. She actually understood what he was saying without her asking him to repeat himself. He stood straighter, and his words were, "I can see the ground better." He had also the blurred vision. This was our first session ever. We have blood work to done. He's a naturopath, so he does other stuff as well. This is a video of that same gentleman. There's no videos on this? There is. Oh, there. Wait, let me go back to the other one. Okay, let's do this. Oh, come on. Okay. So here's him walking. He gives a doctor.
Okay, come on. Cross. Look up. Come on. There you go. Not bad. Slow down. Yes. Cross. Completely cross over. Good. That's not bad. Come on.
He's crossing over.
Look up. Yes. Come on. There you go. That's.
And then this was just him doing a little slap thing with his fingers, which he couldn't do. Here he is doing Incy Bincy Spider, which is really quite remarkable after Parkinson's. Now, this is a really good one. So I did a world tour this year, my second one. So I travel where my instructors are, and I do pro bono work, and I do workshops, and we teach. So I went to Israel this year, and my instructor, I go to his office twice. We do pro bono work on first responders. I always do that everywhere I go. And then I always work with his patients. She did not know him. This is actually the second treatment. My first treatment with her, she came in, and my instructor was like, he didn't see me treat Parkinson's before. So I got to show him how to do this, right? And she comes in, and she literally is like, she's really shaking. And she's pushing a chair, and there's a medical assistant with her, and I'm like, okay, I got my hands full for this one. I'm like, oh, geez, okay. So I have her sit down and, I start needling her. I do 14. I use a 40 millimeter, a nice size. She had actually a little bit of a hump. Got that in good. Do 20, lay her down. She knocks the needle out. Oh, I'm sorry. It's okay. Don't worry about it. Just put it back in. On me in. She's shaking. Soon as I turned it on, I'm not kidding around. I'm going to show you the video. This is what Eli did afterwards, the week after. But when I was there, soon as we turned it on, I'm like, how you doing? And she's like, I feel good. And she was skeptical. She doesn't know us. She was referred to us by a neurologist because they knew I was in town. And I'm like, Eli, when you treat her next week, take a picture of her. Do a video for me. So this is the video of her before. It's the second treatment, though. So look at her moving. She's shaking. And she was worse the treatment that I saw her last time. And then this. Huh. Did I mess something up here, guys? Let's go like, there it goes. Let's go, boom. And then this is after. Motionless. Except for one little toe. It's a 30-minute session. And that's what we're seeing, which I'm really proud to see and be able to share with you guys. That's just Parkinson's. We do a lot of work in a lot of different areas in neuropuncture, internal medicine, mental health, pain, and orthopedics. We use this trinity to help us construct our prescriptions if we don't have them. And this is what we use for Parkinson's. Again, the 21st century medical mindset for us is not quell, liver, win, nourish, kidney, yin. It's, can I target the central nervous system? Can I target the brain? Can I neurorehabilitate the basal ganglia, substantia nigra, and the dopaminergic system? Can we produce more dopamine? Can we help repair the brain and maybe give a neuroprotective effect with some of those neurotropic factors? The answer is yes. That's the prescription. We put everyone in programs. Because with Parkinsonians, like the doctors are all saying, it's not just that, right? We need to have them exercise. And there's some great exercise that's been proven to be really workful for them. It's called intentional conscious walking. So remember, Parkinson's patients walk like this. So you have them walk 3 times a week, stressing the walk. Head up, shoulders over the hips, shake your arms, and purposely, intentionally move your arms. Have them walk 3 times a week, build up to 6 miles a day. This has been really very effective in helping to create those change the maladaptive signatures in the brain. It doesn't obviously cure the condition, but that with maybe a ketogenic diet to feed the brain fats and protein, which heals the brain, would probably be another good component. We got herbs in Chinese medicine that cross the blood-brain barrier. We have nootropics we can use that also help heal the brain. And then we put them on some maybe breath work and those exercises. And that would be our full program. Now, obviously, we're not curing anyone with this. At the end of the 12 sessions, we see where we're at, and we put them on a maintenance plan, okay? And we manage their symptoms, and we manage their condition. There's my references, and thank you very much. I think I made that right on time. Awesome. Thank you.
Thank you, Dr.
You're welcome. Thank you.
That was really great. I think you've opened a whole new, now I have to correct my vocabulary.
That's right.
Neuropuncture. Thank you. That was, let me give you. It's not much, but we so appreciate, especially coming all the way from Florida for us. Thank you.
Mary Jo says hello.
Thank you.